Our next speaker is Dr. Joe Herman, who has also been a friend of mine for a long time. Joe is a radiation oncologist and focusing on pancreatic cancer, and has been at many of the premier institutions across the country, including Johns Hopkins and MD Anderson, and most recently Northwell Health. He also recently, within the last few years, started what we call the Canopy Cancer Collective, which is a collective that's based on improving patient experience or patient's care, comprehensive care for the treatment of pancreatic cancer. UCLA, we were fortunate to be one of 14 centers that was selected to participate in this care network, and it's tremendously helped the care that we give our patients. We not only now focus on the traditional disciplines like surgery or medical oncology or radiation oncology, but also all the other important services like genetic testing and psychosocial services and goals of care and nutrition that Joe will talk about. So what he's done also is very much so a pioneer in changing the quality of care for patients with pancreatic cancer, and has provided the infrastructure through the Canopy Cancer Collective to be able to do so. And as a center that's experienced this, I can say it's made us a whole heck of a lot better. So thanks so much for coming, Joe. Really glad you're here.
Thank you, Tim, for the kind words. It's truly a pleasure to be here and an honor to be here. I want to thank Aggie and also the Hirschberg family for the opportunity to present. We had a very nice dinner last night, and I actually got a ride home. We had a chance to talk a little bit. And I think the one thing that echoed last night is we were talking about pancreatic cancer survival, and that none of us are happy where we are, and we have to take bold steps to move forward and faster. And I think hopefully the one take home for what I'm going to talk about for the next 20 minutes or so is that together we can do more. We can go further, we can go faster, we can be happier, we can feel supported, and we can make a difference. And I will say what I'm going to talk about has not always been easy. There's a lot of work that goes into bringing teams together. There's sometimes you go backwards before you go forwards, and also there's not always agreement in terms of the strategies that you move forward. So I think just acknowledging that that's still okay. And as you know, I think when you're trying to make a difference or take a step forward, embracing the challenges sometimes as well as the successes are what's going to move the needle forward faster. So what is, and I think Tim did a great job kind of getting us started, it's really a learning, what we call a learning health network. We are the first oncology learning health network. There's been other learning health networks that have been mainly derived around pediatric conditions or other benign conditions or ulcerative colitis, where centers, very similar to PRECEDE, where centers come across the country, work together to improve care. And I think our focus has been from the very beginning is what we call mom-level care. It's the kind of care that if your mom or your dad or your brother or sister had cancer, heaven forbid, or have in this room has cancer, what do you really want for your patient or your family member? And how do you know? What centers do you go to? How do you know where to go and get the care that you need and deserve? And as Tim mentioned, we started out with multidisciplinary care, which is rad-onc, med-onc, surg-onc, and what we're going to talk about is really true interdisciplinary care. And if you look in the picture, I don't know if you could see it there, but you have Tim, you have actually 3 different surgeons, and then you have a medical oncologist, and if you look very closely, they're actually playing with Mr. Potato Head. And it was a test, and we had different tables, and we said, okay, how fast can you put Mr. Potato Head together in an organized way and following the guidelines? And it was very interesting to see how each of the tables did it. And it just goes to say, like, when we think about how do we improve care for pancreatic cancer patients, there might be 20 different ways to do it. But regardless, we have to find a way to partner together and make it happen. And as you can see here, the team here at UCLA is unprecedented and truly a wonderful partner with us as we drive together to improve care. And I think the other thing that we evolved to is we started this in right before COVID in 2020, very similar to Diane. And we realized it's really great to have data to show improvements like survival or improvements in outcomes or patients getting on chemotherapy. But if we don't have the patient's voice and if we don't know if what we're doing is making a difference, then how do we know if it matters? And then also, it's one thing to do a good job at the front door. So when we say that, a patient has a diagnosis of pancreas cancer, get the team together and get them down the right track. But who's responsible for making sure that patients get that care through their trajectory? When they get their next scan, who owns that decision in terms of making sure that they're going to get on the right track and stay on the right track? And if they're having a problem or a need, besides just going on the MyChart, how do they get that care, what they need across the trajectory? So again, our commitment is creating deliberate expectation at our cancer centers that you're pledging to give mom-level care across the full trajectory for your patients. So where did this all get started? It actually started when I was coming out of, it actually really started, Diane reminded me, at University of Michigan when I was a resident. The breast cancer team there and also the GI clinic there did a pretty good job of bringing everybody together. And I was very inspired by that model. And when I came to Johns Hopkins, I realized that although Hopkins is one of the top centers in the country, they were not very organized in bringing care together. And if you look on the left, I think it's the left up there too, you could see most patients, and many of you in this room have probably experienced this. You get a test and then you bounce around from doctor to doctor and then you finally, hopefully here at UCLA you don't, but at a lot of places you bounce around and before you finally get that care. But now being deliberate and really trying to make it easier for the patient, come in for one visit and get one-stop shop care and then be able to get therapy started much faster and much more reliably. So at Hopkins, we all got together in a room. We would have very robust discussions. And I think the most important thing is we learned from each other. All the surgeons and all the medical oncologists knew what radiation was. I could talk through a Whipple pretty well, and vice versa. A medical oncologist, et cetera, would know. But also in these meetings, it grew and it evolved into a bigger room where dietitians came in, researchers came in, and it expanded across a full interdisciplinary team. Not only were we able to give better care, but after about 6,000 patients, we showed better enrollment in clinical trials, better genetic testing, and actually we showed a change in diagnosis or management in 30% of the patients that came through our clinic. And what we showed is, this is just one example, is when patients were labeled as unresectable or not surgical at an outside center and then came to our center, we actually were able to get them to surgery. You could see the survival was the same as those patients who were upfront surgical patients. So this is a quick real example is this is what we do in tumor boards, right? We'll show a scan, we'll talk about the patient in a very basic way. We'll say the patient presented with abdominal pain, and sometimes might get a story, may not get a story about what the patient wants, what is the stage, and that maybe the patient wants to be aggressive. But as we were talking about earlier, what about all these other things that matter, and who's really paying attention to these things? Is anybody deliberately looking at, do they have supportive care needs? Is there access barriers? Are there financial challenges? What does the patient really want? Are we asking the patient and family what they need and what they want? What do they expect out of their care? What clinical trials are available? And then also, again, who's going to manage that care across the full trajectory? But to go even further is, what stage is the cancer? Who decides? Is it the surgeon? Is it the medical oncologist? How do we know if that care was delivered? What's even the standard of care? And what are other cancer centers doing? And I think this is just a survey that I copied and pasted from a meeting that I was at where I was asking for a patient with unresectable pancreas cancer, what is the standard of care outside of a clinical trial? And as you can see, by all the different responses, there's not really one standard of care. So what are you supposed to do as a patient, as a family? Who do you listen to? How do you know what's right? There's a lot of stuff on the internet. How do you make sense of it all? And so what we set out to do is to create this learning health network where we could work across centers, collect data, and learn from each other in terms of how we can better improve care and address all of these issues, the lack of standardization. The other reality is that our doctors, our nurses, our advanced practitioners, our dietitians, they're a little burned out, right? We're a little burned out too. We need help, we need support from each other, and building teams together help us get through the day and help make our work life also enjoyable. And if we're happy, that means we can give better care also. So it's just this sort of circle of dual support and helping each other manage this really tough cancer. And then I think, so again, the goal of Canopy was really this continuous learning and improvement across centers and learning from every patient, improved experience for providers and patients, efficient, integrated, multidisciplinary, and interdisciplinary care. So again, really paying attention, how many visits are we asking patients to make? How much time are they spending with their care, and how do we make that easier so they could spend time with their families? And then finally is being very deliberate about helping make sure they get on trials, that a lot of the stuff that Diane talked about, that, you know, how do we make sure that they're getting genetic testing, et cetera. So just briefly, this is basically the structure of a learning health network. It starts with creating a vision. It then is a focus on continuous learning. So again, learning from the data to make quick decisions, not waiting till a manuscript comes out several years later, but learning from each other in real time now, sharing that data transparently across centers. And then also just building trust. Instead of, right now in academics, there's a lot about competition. How do we get the first paper out? How do we get that grant? So sort of taking that aside and saying, okay, that's important, but how do we put the patient at the center and learn from each other? And then co-production, working across disciplines where everybody has a voice, everybody is welcome to have something to say, and then finally the governance around how do we manage this. So this started right before COVID. What you can see is in the front there on the right is Joni and Scott Krenz. Joni was diagnosed with metastatic pancreas cancer approximately 7 years ago, has been through multiple treatments, is currently disease-free and is alive and well. Her and her husband really were frustrated with the care that they got at some of the centers they went to. I won't name who they are, but they did not feel like they were getting the care that they thought they would be getting from some of these top-name hospitals. Had heard what we did at Hopkins, had heard what's been done at other centers, and invested in this collective. And in the beginning, it was really this focus on bringing people together to improve care in a comprehensive, coordinated way, with a focus again on the patient. And again, we launched Canopy from there. So we started out small. We wanted to make sure that we could leverage and learn from the first 6 centers. You could see the first 6 names here. And then in years 2 and 3, we expanded here, and this is where we welcomed UCLA and some of the other California programs into the program. And now we're expanding out to other centers, very similar to Proceed. And actually, we were chatting a bit, there's a lot of overlap with the centers that we work on together. So as we evolved our Canopy Cancer Collective, our mission changed a bit, where we again realized that we were doing a pretty good job. After a couple of years, the front door was pretty solid, that patients were getting what they needed, but we still were not doing a great job across the trajectory. And we realized the only way to do that is every single member of that team that's taking care of those patients has to be in on this plan, and making sure that everybody's going to work together to make sure nothing falls through the cracks and the patients get the care that they need and deserve. In addition to that, working with PanCan, who had actually published and put out some expectations around what they call right track care. So rather than starting from scratch, we thought it'd be good to kind of align with pancreas cancer, the Pancreatic Cancer Action Network, and also other organizations like the Hirschberg, and how do we move care forward faster? So again, with intent, we really asked centers to reach out to their other team members, exercise physiologists, pastors, social workers, sociologists. How do we build the team up front to really serve the patient across their trajectory, and again, increase that access to oncologic and supportive care? So one quick example is that in general, across our centers, patients that need palliative supportive care could only get it about 15% of the time. In addition to that, we found that if patients did not get goal concordant care, or basically what NCCN guidelines suggest, survival was typically about 50% that of those that actually did. So with all that data, the focus really transcended to some of these things that are hard. I would say they're not maybe always sexy, for lack of better words. For example, cancer centers focus on grants, publications, funding, all these things. When you ask them what is their commitment, what is the funding to patient care across the trajectory, you get a blank stare a lot of times. There's not a strategy. There's not a clear plan. And if you ask them about their data, they really don't have any. It doesn't exist. So we wanted to create that expectation. So building the teams, and also this is our learning network where we brought in teams from across the way. You could see UCSD there, some from Northwell and Hopkins, is also asking them to bring their administrators. Make sure their administrators, their cancer center directors understand the importance and really put an emphasis on supporting. And I'll give you a quick example. A lot of doctors, they evolve in their careers by getting promoted to assistant or associate professor, and most promotion committees have little to nothing about care improvement or the care that they're delivering to their patients. So we're trying to change that. And so I wanted to give you, it's kind of busy and I apologize, but this is really the great work that Tim and his team have put together, is intently listing every single member of the team, not only who they are and what they're doing, but what % effort do they have, so they can show their bosses and their bosses that they clearly don't have enough, or we need another person, or we're not meeting the needs of our patients. And so we wanted to expand and make sure that again, there's data behind the work that's being done to make sure that all of you and all the patients get what they need. And so in October of 2022, we had about 100 of us in a room like this, and we said, what is something that we want to do together that we think will have impact, that's hard to do, but will have major impact? And this is our abstract that was just at ASCO GI, and it's busy, so I tried to break it down here. Is we looked at our data that we had within our database of about 1,800 patients, and we realized that patients were not being screened for some key things. So clinical trials, pancreatic enzymes, palliative care, and goals of care. Less than 50% of patients in general were getting screened for these things. And within 1 year of asking every center to set up programs around these things, to have accountability, people that are going to own it, and then collect data on these things, you could see that pretty impressively, every patient was getting now these services. The other thing is that we need to learn from every patient. The only way to do that is to collect data on these patients and make sure that we learn from each one. So this is just a quick snapshot of some of the data that we have. We actually have over 4,000 patients now. Admittedly, nothing's perfect. We did support these centers with some finances. I will say that, still with all that effort, they're still missing data. There's still things and processes that we work through. But again, overall, we've learned a lot from the patient populations at our centers. And I think one thing I'll just mention is that roughly 10% of the patients with pancreatic cancer in this country are seen at these 14 centers. So we have the ability to really impact change very rapidly. And so you could see here, this is actual data across our patient population with at least 2 months of follow-up. And we have that just because we want to make sure patients are mainly getting their care at these centers. And so this is our baseline, and this is what we're now looking at regularly and managing. And that way, this is important as we do certain improvements, as we look at different, if certain centers are, let's say, using FOLFIRINOX versus Gem/Abraxane, or certain centers are using ctDNA, or certain centers are implementing more patients on clinical trials, we then have hard data showing that it's improving survival in different patient populations. So now, I think the next thing we realized is that this is hard work, and I think Tim could speak to this. This is not easy work. You really need to get in the trenches. You need champions and leaders that are committed to do this. And again, I'll just say it's one thing to do it at the front door. It's another thing to do it across the trajectory. And I think the other thing that we just really recognized is that we don't, as physicians, we don't do a great job really listening to our patients. Partly, maybe we don't have enough time. We don't ask the right questions. There was a paper that was just published on the Alliance stereotactic radiation trial by Rebecca Snyder at MD Anderson. And what it was, very simple study, what toxicity data was collected by the physician and what toxicity data was collected from the patient. And it was amazing how different it was and how underreported physicians were reporting that information. So it just raises the bar that we need to do a better job of getting that information. So what are we doing right now? Right now, we are very specific across our centers, in addition to doing what we called our screening aims that I showed you. And again, I apologize, it's a little busy, but I just wanted to kind of outline, these are the areas that we're focusing on. So number one is making sure patients at all these centers are getting the right tests. So germline testing, staging across a trajectory, and we're holding centers accountable to say 80% of all the patients you see should get this done, and also having it be time bound. So it should be done within 3 weeks of the visit. It shouldn't happen 5 months later. There should be some accountability. In addition to that, the right treatment, that we should screen patients for trials. And what's really cool about screening is centers would come back and say, it's not that we're not screening, we just don't have trials. We don't have enough trials for our patients. And then we started talking about how do we start sharing trials across our groups and make sure that at a minimum that 10% of our patients are being enrolled in clinical trials. And then finally, that we're asking patients, what do you want out of your care? How aggressive do you want to be? What are you looking for? Is there something you're trying to get to, whether it's a wedding or a birthday or a graduation, and how do we help you get there? And then these seem like simple things, and Shelby's going to talk about this in a little bit, but when you ask centers, are you screening people for enzymes? Are you giving them enzymes when they need it? They're like, of course. But then you ask where the data is and they don't have it, right? So we recognize that many weren't. Many oncologists honestly thought somebody else was doing it. They think, oh, the dietitians are doing that. But then we find out they're not seeing a dietitian. So they're not getting that care. They're losing weight and they're not even aware of it. And then finally, again, I mentioned this is very, our patients don't have enough access to these services. And unfortunately, again, cancer centers don't really recognize the importance of these centers all the time and of these services. So again, we're trying to collect data and show how woefully understaffed these groups are. So as I mentioned, we need to make sure that we hear from the patient. So we've also built in patient-reported outcomes of questions like, I felt heard and understand by this provider and this team. I felt this team put my interests at first. And then, just kind of basic things. I know who to contact if I have a question. I am confident that I will receive the help from this team if I have questions. So I just, to highlight the team here at UCLA has done incredible work. And really, it's been neat to see you guys really come together as a team. And not only are there the Canopy goals and the Canopy missions, but each of our centers look at their own needs, their own problems, and what they're going to address. And here you can see this is the one-year SMART aims that Tim and the team had put together, focusing on, again, keeping people on the right track, as we talked about, patient-reported outcomes, building out a 5-year plan. So also, a lot of times when we went to these centers, what's your 5-year plan or your 3-year plan to help improve patient care? And they just say, we don't have one. We have one on grants or NCI designation. We don't have a plan for taking care of our patients. And then obviously, without support from organizations like Hirschberg and Joni and Scott Krenz and others, these programs really won't exist. And again, as we get the data, hopefully we'll continue to support that. This is just highlighting, as Tim had mentioned, really the integrated practice units being developed. And I'm not going to get into the weeds here, but just acknowledging, again, the deliberate plan to put these programs in place to make sure that every patient gets access to them. And this is just a real-world example, is how does this actually happen? Well, the teams meet generally every week, and they look at their data, and they look at how they're doing. And you could see here, this is for making sure that all patients get palliative care referrals. And you could see it bouncing around in the beginning, but now, pretty much regularly across the board, there's a plan, the details have been worked out, and essentially the gaps have been remedied to make sure that there's no problems moving forward. And this is really nice work that Emily put together. It's a little busy, but I think just to kind of break it down is that every single patient now that walks in the door at UCLA will get an individualized supportive care plan that walks through at baseline, and it gets reevaluated through the trajectory of care for each patient. And the way this is done is it's really a true partnership. Again, remember we talked about the whole team. So you could see here physical therapy, genetic counselor, palliative care, dietitian, social worker, integrative medicine. And so layering this support staff, but then also bringing in all the other disciplines into one team that are all responsible to follow the patient through. But then you kind of need, the ability to adapt as the patient moves through that trajectory. So this individualized care plan gets reevaluated every 2 months during a scan or follow-up. But the other part about this that's so key is having navigators, having nurse navigators, lay navigators in the community, and so building this up. And what's really exciting right now is their payers are starting to pay for navigators. American Cancer Society has built a program to train navigators, and I think, kind of putting the navigators at the center with the patient around the interdisciplinary team with a clear plan for every patient is again, hopefully where every patient will get that same level of care. So now, just how do we actually do this? There's a lot of different ways to do this, but CareVive is a online platform that allows the patients to continuously give feedback of how they're doing, and it also provides education and information. So here at UCLA, you'll be one of the first to really partner and test this foundation. This platform has been used at many other cancer centers, including UAB. There's actually a R01 going out very soon to sort of build on some of the work that's already been done. And just to kind of give you a sense of how this works, you would essentially prescribe this to your patient. You'd say, Mrs. Jones, we'd like to enroll you into this program called CareVive. They get an email, they sign up for it, and instantly they start getting educated, even before they come in for their first visit. And then again, it constantly is asking, not constantly to the point where it becomes overwhelming, but again, there's keys and questions that provide that data back to the physician and the team so that they can act on it quickly as opposed to waiting 2 months until the next visit, for example. And then in addition to that is based on their symptoms, it automatically uses AI to be able to say, these are some things that you could do. So if the patient says, I have pain, it then asks 2 or 3 more questions about their pain, and then it could turn out that that pain's not from their cancer, but it's because they're not taking enzymes, and they're actually having gas and other symptoms. So the goal is to really utilize this to be able to drive forward and help the patients also manage themselves and be educated on what's needed. And here's just a couple patient recounts of using the CareVive system. You know, even though it's an invisible hand at times, I feel like, you know, they're there for me. I always can reach out. And also, the most important thing about this is it alerts the interdisciplinary team of when something is needed. Right now, you know, you might use MyChart or whatever to reach out to your team, but who's owning that? Who's keeping track of it? This is really a way that it alerts when the patient really needs something or the caregiver needs something, they're alerted of it. So in summary, over the past 3 years, we've really focused on, with these 14 centers, is partnering with each of the centers to learn about their centers. We also have patient advisors like Ray, who's here in the audience. Not Ray, Jay, sorry, Jay, in the audience that has been intricate in helping make sure that the patient's voice is integrated into the plans. We've also built out this platform to really learn from every patient. And again, we have set up what's called BAs and DUAs with every center to be able to use that data for quality improvement. We're also partnering with the centers to make sure that these track measures are accounted and followed at each of these centers across the full trajectory. And then as mentioned, we're focusing on making sure that the patient's voice is heard as we go through this. And then with a few of our sites, UCLA, UCSD, Hopkins, and others, we call them our scout sites. They're the centers that are really helping guide and lead our strategy together with us. And where we are now is with our 14 centers, we feel like we have relationships, we have a good system in place that we can do small clinical trials, maybe not big randomized studies, but we have the ability to do small clinical trials or ask small questions. And for example, right now with Natera, Signatera, we're sharing data together and learning about which patients that got ctDNA, for example, or circulating tumor DNA in the blood is right now it's controversial as whether that helps patients with pancreatic cancer. So across our 14 centers, we're looking to see if ctDNA is a solid biomarker to help drive care and improve outcomes for patients. And then in 2025, we're going to be expanding to more centers as we grow. So with that, I appreciate the time and attention, and I'll take questions.
Okay. Just one question. My dad is a pancreatic cancer survivor, and so was very involved in, his care and stuff. But I think one of the things that I found was, to your point around sort of tumor boards and interdisciplinary teams, like there was still no quarterback for us. Yeah. And so I'm curious, like, what are the best practices around who is kind of that single point of contact for patients and families? And like, what do you see as sort of the best model there?
Yeah, it's a really good question, and I think it's not an easy answer, and I obviously can open up to my colleagues here too. When I first started my career 25 years ago or so, when we started our multi-D clinic at Hopkins, if it was a patient with metastatic disease, it was essentially the medical oncologist was sort of the quarterback with their team, their advanced practitioner, et cetera. When it was a patient that was going to get radiation, I was the quarterback, and then if they're going to go to surgery, then the surgeon. And we kind of did it more in a baton way, kind of I'll start out and then we hand it off. The cool thing is that all of us could speak to what we all do, So if we had to fill in a pinch or answer a question or address something, we trained each other up to be able to do it. I think as we've expanded, where more advanced practitioners are now partnered with us and working in teams, and even in some cases run the clinics, for example, they become that point of contact that can then reach out and find the right quarterback. And then I think where we're going in the future, though, to kind of get to that point is, I really think this is where I do believe that using technology to help to some capacity triage to the right person, right, in an easier way. And then I also think educating our navigators to really be at the top of their license and answer the questions that are probably straightforward, and then have an easy way to then go to the right quarterback, right, per se. And it's funny to use the word quarterback because that's exactly the word that we use, because it is kind of who has the ball right now and who's the go-to person. So I think it's evolving to where, and I think this is one of the coolest stories I'll just share is the coordinator now at Hopkins right now. She was a clerk at one of the, working at one of the surgery floors, and started working with us, and then partnered with the coordinator. And she then went back to school, got her nursing degree, got an advanced degree, and now she runs the whole program. And I think what's exciting is just to see that every single person grows to be at the top of their license and be able to support patients. And that gives us the ability to lean on each other. I think what I think, I think Shelby and these guys will talk about, if anybody gets called, they're not going to say, well, that's not my problem. That's not for me. That's for this person over here. It's like, how can I help you? What can I do to get you to the right person? And then text each other if need be to be like, hey, Tim, I need you to talk to Mr. Jones. He's really having a tough time. Can you get to him? So I think it's kind of creating that relationship of relying on each other and really the relationships that matter. So I think it's evolving.
Hi, Sonia Riker. Thank you very much for this amazing presentation. And clearly, to set up the system like that, it requires quite significant investment of resources. I work for Department of Health Services that serves a very large underserved population within LA County. And the resources are not always there. Any suggestions how to start in the environment that is lean?
Yeah, it's a really good question. I will say resources is often the challenge, right? And I think where we're evolving as an organization, we were very fortunate to have very generous supporters, and I think that that's not sustainable, right? So where we're evolving now is to leverage the centers that we work with now have come so far, and what we're learning is that a lot of the vendors want to work with these centers. They want to learn from these centers. They want to also invest in these centers because they see the teams. So, for example, I'll just say one of the pharmaceutical companies wants to do a small trial looking at quality of life with their drug, and that's a kind of perfect trial for us to do as an example, and they're willing to sponsor us and provide resources. And then our goal is to use those resources and pass them back down to the centers to further the support and build out the infrastructure. And then ultimately, as we have these different sources of revenue coming in, for lack of better words, then we can, again, give it back to the centers and let the centers then fill the gaps that they have. So I think it's really kind of cool to see the evolution. Some of these, for example, is a company called Mapletree that does exercise physiology, and she doesn't have a lot of resources, but we're going to partner with her, and those centers that want to help her, we're now going to payers, and we're going to use our data to support that payers need to start paying for these services so that our centers can actually get them. So we're trying to be proactive in different avenues to help fill those gaps.
Thank you.
No, sorry.
Yeah, what's the most efficient way for a patient with metastatic disease to pick a clinical trial?
That's a really good question. And again, I can open this up to my colleagues too. I think the first and most important thing is to, I still think it's worth doing a little bit of homework, just at least understanding the basics. And then I would also say then, I do believe seeking a center that has a team like UCLA or UCSD, if you can get to that center at least first in the beginning to learn about what your options are and understand what the pathways are, and then even going back and getting care closer to home, but then having some connection to those centers. And that's something that we're trying to work through, is recognizing not everybody can get their care at UCLA. They have to get it in the community. They can't drive and go back and forth in the city. So I think it's starting with a center that has a lot of experience and access to clinical trials, then partnering with them. And then I think the second is there are a lot of new tools out there using AI integration. There's a company called XCures that actually will take your data and they'll look across different centers nationally to see what trials are open out there that fit your specific profile. And then I don't know if you want, I think it's not easy still, but I don't know, Eileen, if you wanted to just, not to put you on the spot, but.
Thank you. Yeah, no, I think this is a really important topic and one which we don't have a good solution, because a lot of times it does fall on the individual person and their family and their sort of networking and resources to identify these. And no question, it needs a bigger local strategy, but it needs a national strategy. And thank you, Joe, for all you're doing. This is terrific. It's one way, right, of just promoting collaboration and access and making people aware of what these resources are.
And I think the one thing, thank you so much. And I think the other thing I'll just mention is with Diane and the great work that she's doing and with Precede, which is kind of almost the front door. And then I think some of the work we're doing in combination with the Hirschberg Foundation, I think together we can show examples of, this is complicated stuff actually to kind of collaborate and bring all this together, but we can show examples that can be quickly adapted and repeated by others so that there's many, many more centers out there that can give you that same level of care and access to those trials moving forward. Thank you. Oh, I'm sorry.
Hi, I'm a 3.5-year thriver and a former oncology social worker. And I have a question about what is the specific role of a navigator and how many navigators should be at each local hospital that's part of this canopy.
Yeah, and I think this is something that we are, to be upfront is learning together. I think first of all, it's defining the role of the navigator, right? And I think there's many centers, and maybe Tim can, I'll let the team speak to how they do it here, but at a high level, I think that there's navigators that live within the institution and help navigate care, clinical care, but then there's also lay navigators that can exist in the community that you can educate about specific cancers that can be sort of also help lead different programs. So like, for example, Jay is involved in a group that provides support where they get together regularly, and I was able to be part of it a couple times. And basically, in a lay way per se, is providing that support, that education and understanding and helping navigate the patient to where they need to go and the kind of questions they need to be asking. At the other level, I would say that there's, nurse practitioners that are really navigating the clinical care, and then there would be navigators that would be maybe even at different levels of education and training and experience that would be more of, I would say almost like just kind of there and almost when the patient comes in, walking them to their appointments and throughout. So I guess the best way to explain it is that I don't think there's one definition right now, but as we continue to justify the reimbursement strategies around navigators, it's defining those roles as the most important and differentiating what kind of experience is needed, what are the services that are being provided, and then having the top of license expectation to deliver that care.
In conjunction to what you're saying, in the old days, clinical social workers, medical oncology social workers, were assigned to patients on a unit or whatever, and they did that role of navigating each and every patient, having rounds, discussing with an interdisciplinary team every week, following patients and guiding them so patients weren't left to try to find resources themselves. What happened to clinical social workers' involvement?
Yeah, I mean, I'll just say that, you know, at Hopkins and MD Anderson, we were lucky. We had a good number of social workers that did exactly that and helped support the system. I think the sad thing is that a lot of the centers, it goes back to being upfront, is that it's
Money.
not always easy to find the funding for those. And unfortunately, without data, a lot of cancer centers typically don't support those roles. And it's sad and it's unfortunate. And I think, again, this is where building that true interdisciplinary team, including social workers, and understanding what can each of us do to make sure that the full expectations of care are delivered. So I agree with you and support that, and I think anything that we can do to, again, continue to raise awareness of the role that social workers do and the amazing things that they do to help patients on a day-to-day perspective and also through the trajectory is imperative.
One quick extra question is, what's the feasibility of getting more local patient feedback? I think the app is a good idea, but there's nothing like real patients going through the stuff at various institutions, talking with the team, having some team representative.
Yeah, and we have patient advocates from the very beginning that we've worked with, and I think that was very helpful for us from the very beginning as we build out a lot of the programs. Now each center has their own patient advocates that work with them during this process. So each of our sites do have patients that are part of the program, part of the development of these programs to make sure that as they're being developed and where the gaps are being assessed, that their voice is being heard.
And how can people get on those teams?
So that's a good segue to Tim. I think, you know, if anybody's interested, I would suggest reaching out to the team at a local level, and then they can pull you in.
Thanks so much, Joe. Great talk and really incredible program with Canopy. You know, we look at the care that we're giving, and it's so much better now. And as he said, it's so much more mom-level care than we were giving before we participated in this learning network. Look at all the supportive services and experts that he listed there. And we didn't have any of them before we started, or many of them before we started working with Canopy. And it's been so great. To get to Judith's question, you know, when we were deciding our Canopy goals this year, various team members were talking about some things here, some things there. But what we're going to do is we're going to go all chips in on patient-reported outcomes. And we're going to work with this app and develop this app and make sure this app is available to all patients who are seen with pancreatic cancer across the whole UCLA health system. And it would be great to also work with some of the underserved communities in Los Angeles.